All right, welcome everybody. My name is Joanna Wykrzykowska from Groningen. My co-chair is missing in action, so I'm going to do the introduction for him. But we're in this exciting session, The Future is Now, QFR and RMS to optimize coronary artery disease patient management. And without further ado, I would like to introduce my dear friend, Professor Yoshi Onuma from Galway, who will talk about QFR from planning and evaluation of the PCI results.
Thank you, Jonah, for a nice introduction. So my talk is about planning and evaluation of a PCI result by QFR. So angio-based FFR, including QFR, was developed as an alternative to wire-based FFR. Potential advantage of this approach is there's no need for the invasive pressure wire, potentially reduce the procedure time, patient risk, and patient discomfort and cost. Angio-based FFR, such as QFR, was well validated against wire-based FFR in terms of its diagnostic performance and area under the curve. Since QFR is based on angiography and able to provide the vessel size, QFR can be used for the planning of the procedure as well as optimization of stent post-procedure. So these are the list of the commercially available angio-based FFR software. QFR is one of the first software developed. The software requires 2 angiographic projections at least 25 degrees apart. The software was validated and studied in multiple clinical trials. Time to computation was initially reported as 4.4 minutes, but with the newer iteration of the QFR software, the computation time is substantially reduced. And in the next talk, we will see actually how to use this QFR in the cath lab. Favor to Europe-Japan trial look into the sensitivity and the specificity of the QFR software in terms of in comparison with the wire-based FFR, and they found that the sensitivity and the specificity of the QFR were 86.5 and 86.9% respectively. The area under the curve of the QFR was as high as 0.92 in that study. Favor 3 China further look at the clinical outcome of the QFR guidance versus angio guidance, and in that study that they found that by doing the QFR guidance, the MACE rate was significantly reduced at 1 year. This is a large trial conducted in China, including the 3,847 patients, and the difference between these 2 arms seems to be also increased after 1 year up to 2 years. So after these clinical studies, that QFR is positioned as a Class 1B recommendation in the European Society of Cardiology CCS guidelines published last year for the functional assessment of epicardial artery stenosis severity during invasive coronary angiography, and also for the assessment of the procedural risk and post-procedural outcomes. However, so far the clinical evidence is focusing on the selection of the region to be treated by QFR, but it's not really focusing on the post-procedural QFR evaluation. So what do we know about post-procedural QFR and clinical outcomes? In the Syntax 2 trial, that we look at the correlation between the post-procedural QFR and the event. In this patient received the 3 stents in the 3-vessel disease. And we look at the post-procedural QFR in the right coronary artery and the circumflex. The QFR value post-procedure was high, 0.96 and 0.94, and those 2 vessels didn't have any event. However, in the LAD, the post-procedural QFR was 0.83, and this patient actually had a stenosis in the edge of the stent and resulted in the repeat revascularization. So if we really stratify the vessel according to the post-procedural QFR, if the post-procedural QFR is equal or greater than 0.91, the event rate was 3.7%. However, in the patient, the vessel with a low post-procedural QFR value less than 0.91 has much higher event rate of 12.10%. Similar observation was made in the Hawkeye registry. Slightly different cutoff criteria, but basically the post-procedure QFR really divide the outcome of the vessel. So vessel with the high post-procedure QFR greater than 0.89 has a low event rate of 3.5%. However, in the vessel with the low post-procedure QFR value equal or less than 0.89 had a higher event rate of 25%. So these are the recent and ongoing angiography-derived FFR guidance studies. Recently, there's two publications in the Lancet, FAVOR 3 and FLAVOR 2. Pioneer 4 is still ongoing, and also in the later this year or next year, we will hear about the FAST 3 and ALL-RISE, which is a comparison between the different type of the FFR, angio-based FFR software versus the wire-based FFR guidance strategy. So just to look at the FAVOR 3 and FLAVOR 2, FAVOR 3 was comparing the FFR guidance versus QFR guidance conducted in Europe. And if you look at this Kaplan-Meier curve, that QFR did not really achieve the non-inferiority to the FFR guidance in terms of MACE at 1 year. However, in the most recent publication of the FLAVOR 2, which is a comparison of the QFR and mu QFR guidance versus the IVAS guidance, the result of the clinical outcome, this group is almost identical, 6.3% or 6.0% at 1 year. And actually, this study achieved the non-inferiority of the QFR or MUFR guidance to the IVAS guidance. So it looks like the study results are somewhat contradicting or the conflicting. If you look at the design of the study, that's the FAVOR 3 Europe used the QFR, FLAVOR 2 used the mixture of the QFR and MUFR. That's the one difference. A number of the patients were more or less same, 1,800 to 2,000 patients. Pre-guidance was more or less same. It's a cutoff value of 0.8 was used. However, if you look at the post-guidance, there was no specific guidance for the FAVOR 3 Europe, whereas there's quite a clear guidance criteria in the FLAVOR 2. And maybe that contributes the difference in these two trials. A primary endpoint is more or less same between these two trials. So I think one of the key differentiating factor is the post-procedure guidance for the QFR, mu QFR guidance. Pioneer 4 trials is ongoing. That trial also in all-comer PCI population, comparing the angio-based FFR guidance versus the usual care. In that study for the QFR arm also has quite clear the post-procedural guidance criteria of the QFR equal or greater than 0.91, or the gradient of the across the stent should be the equal or less than 0.05, and the interim result of this study will be available later in this year. So as a conclusion, QFR has proven clinically feasible and effective as an alternative to wire-based FFR. QFR has shown superiority of angiography-guided PCI and received the Class 1B recommendation in the ESC guidelines last year. Post-procedural QFR also predict outcome after PCI and supporting its role in optimizing interventions. In the FAVOR 3 Europe trial, the QFR did not achieve the non-inferiority. In contrast, the FLAVOR 2 trial comparing the QFR, MUFR guidance versus the IVAS guidance, the non-inferiority was achieved. Likely due to the use of the post-procedural QFR optimization, one of the key factors in the differing outcomes. Ongoing trials such as Pioneer 4 will be further clarify this answer of the issue. Thank you for attention.
Fantastic talk, Yoshi. Any questions from the audience? We have a little bit of time, I think, or from the panel for Yoshi.
Yoshi, yeah, that works. Nice talk. Thank you so much for showing this data. I mean, the question to me would be, do we need all this hard, clinical endpoint data with all these different technologies? Is it needed? I mean, as long as we showed, that QFR is as good as other technologies, do we need to perform these randomized trials with hard clinical endpoints?
Yeah, I think what you mean is some sort of a class effect of this type of the softwares. What we have seen that we have some core of comparing a different type of the software. I think there was some variation in terms of diagnostic accuracy of these softwares. Although when we compare that in one of our studies, we could not see the statistical significance between these 5, 6 softwares. However, I think there was some difference between these softwares, and especially some software used only one view, and some software use 2 views. And I think acquisition is really the key for the performance of these type of softwares.
Yeah, do you think that also in addition to the post-PCI check that you achieve the QFR above 0.91, it's also the quality of the imaging that also determines how good your assessment will be and what your results will be?
Yes, yeah, I think, yeah, at least you have to have 2 projections to be able to assess the post-procedural QFR assessment. But I think that's also very important because you are not really relying on your eyes only, but there's some objective measurement that you can really rely on. So.
Great. Now, thank you. So let's go to Andrea Enriquez, who will actually show us how it's done in practice, what you need to do in order to achieve the good measurements, practical clinical experience with next generation solutions.
Thank you for the presentation. It's a real pleasure to be here at this symposium. To present QFR and CCTA for clinical decision-making and optimal PCI guiding. These are my disclosure. Well, my presentation will focus on these 2 different topics that are non-invasive functional assessment with the quantitative flow ratio, and in particular the new version of the software, the 3.1 version, and the use of CT coronary angiography for the guidance of revascularization. Starting from QFR, this technology can be used in different clinical scenarios, as highlighted by Professor Onuma, from chronic coronary syndromes to acute coronary syndromes, and also for the guidance of the revascularization. But I want to focus my attention on the acute setting, because probably one of the main advantages in the daily clinical practice of using QFR regarding the assessment of non-culprit lesions of patients presenting with acute myocardial infarction and multivessel disease. And at this purpose, I want to show you, I want to share with you a typical clinical case managed with the QFR 3.1 in a patient presenting with an ST elevation myocardial infarction and showing this coronary angio. So basically a clear culprit lesion on RCA and non-culprit lesions on both the circ and LAD. And after the treatment of the culprit lesions during the primary PCI, the patient was then assessed in an offline setting for both non-culprit vessels, showing a non-significant result on the circ and a positive QFR value below the cutoff of 0.80 for on LAD, identifying hence non-culprit vessels that need to be treated with a staged revascularization. And at this point, the software, the 3.1 software of QFR is able to provide a lot of further informations other than the general value of functional assessment. Informations like the pattern of disease thanks to the virtual pressure pullback gradient, as you can see in the mid of the slide, and informations like the delta QFR, the residual QFR, the lesion length of each lesions in case of multiple lesions along the vessel, as in our case. And all these informations automatically detected by the software are very useful for us to define an ideal procedural planning for the revascularization of the vessel. And in our specific case, we plan to treat only the proximal lesion, because that was the one with the main pressure drop, the main delta QFR, and an ideal residual QFR. And so we plan to put a single stent on proximal LAD, as you can see in this slide. And following this procedural planning, we obtain a good angiographic result, confirmed also by the post-PCI functional assessment, in which we obtained a QFR value of 0.91, so an optimal result, especially for LAD, without significant pressure drop inside the stented segment, and with a residual non-significant pressure drop on distal LAD. Lastly, for QFR, I want to show you how the 3.1 version of the software can be easily used in the daily clinical practice for live QFR computation inside the cath lab without the need for other operators outside the cath lab to perform the analysis. In this case was performed by myself and my professor Gianluca Campo, as you can see on the left of the slide, of a patient with chronic coronary syndrome and intermediate lesions on both circ and LAD. And thanks to a portable touchpad with Bluetooth connection and a sterile cover, we were able to perform the computation on real time, as you can see on the right of the screen, on both vessels in very few steps and in very few minutes. Well, similar informations useful and helpful for cardiology, for interventional cardiologists, can be obtained also with coronary CT angiography. And this technology can be used for both the diagnostic part, so to detect coronary artery disease, but also, and probably mainly, for the interventional part to plan and guide their vascularization. And this is possible thanks to the ability and the capability of CT angiography to provide a lot of information, starting from the best catheter selection, the best working projections, but mainly the need for dedicated operators or dedicated devices for an adequate lesion preparation in case of complex lesions, in case of heavily calcified lesions, or the presence of CTO, and so on. And again, let me show you another clinical case managed with this technology in our center. This was a case of a patient with effort angina that was sent to perform a CT scan that revealed a multivessel disease with especially, and in particular, a long occlusion of LAD with high calcific burden. And these are some example of informations acquired during the CT scan, so the coronary ostium origin for the catheter selection, the reconstruction of the vessel in the center of the slide, and also the calcium view with informations like the calcium arc, the calcium thickness, the calcium density, and so on. After that, the patient was obviously referred to our cath lab to perform the coronary angio that basically confirmed the anatomy evidenced with the CT. So basically a non-significant lesion on our RCA ostium, a short subocclusion of obtuse marginal, and in particular a long CTO of the LAD starting from the ostium up to the distal part of the vessel. And thanks to all the informations acquired during the CT scan with dedicated operators for the presence of the CTO and dedicated devices for the lesion preparation like the IVL, we were able to perform a complete revascularization on both vessels without any kind of surprises during the procedure. So, in conclusion, my take-home messages are that nowadays an angio-based revascularization is outdated in most cases, and this is because we have different tools available in our cath labs to achieve optimal results for our patients. And in particular, QFR is very useful in both stable and acute settings to identify lesions that need to be treated, but also to guide and optimize the revascularization. And this probably especially in patients with acute MI and multivessel disease. And on the other side, the CT coronary angiography is a very helpful and good strategy to define an ideal procedural planning for the revascularization of stable patients before referring them to our cath labs. Thank you for your attention.
Thank you, Andrea. Very good presentation. So I think the first two talks are focusing on QFR and CTA. So maybe we can take 2-3 minutes here to have a conversation with the speakers, but also with the audience if you have any questions. So Andrea, Yoshi, if I may, QFR is a DPO technology, D for diagnosis, P for planning, and O for optimization. This is an advice for free to the marketing teams here. So the DPO algorithm has been born today. So the DPO is diagnosis, so you can have a diagnosis also with CT data as well. Planning certainly with both, but I think the optimization part is unique, and I think you addressed that in your talk, and you show some examples on how you optimize. And this may bring this technology to the next level, and if you see the last results by the Flavor 2, maybe to be comparable to even IVUS, right? So do you agree this could be the new algorithm going forward?
Yeah, I think you have a very good talent on the marketing. I agree with the DPO should be the mantra for this technology. I think optimization is certainly, I think, very important to really have a good PCR result long term.
I totally agree with you. I cannot add any.
With the new version, do you agree that this should be and could be implemented easily? First, you have all the Bluetooth connectivity, but also the interaction with the new 3.1 version. It makes your analysis way faster, even for online use. I mean, because for the optimization, you have to be performing that in the cath lab, right? With the planning and diagnostic could be done before, right? You have more time,
Yeah.
but for the optimization part, it really requires a good user interface. Do you agree this could be a good way to do that?
Yeah, for sure. The right way is to have a software with very few steps to perform the analysis, very few minutes to have the analysis inside the cath lab. So in order to have all the informations for the planning and for the post-PCI evaluation of the result.
So one more question to you, because we sort of tend to use IVUS on complex lesions only. How do you use QFR? Do you use it in all patients in your cath lab, or do you also make a selection?
No, for sure we make a selection. We use also imaging in some cases. There are some cases where QFR can have some limitations. For example, for ostial lesions, for left main lesions. So in some cases, QFR is not the best option for our patients. So is a tool like other tool like FFR, like imaging for the best treatment for our patient in order to achieve optimal result.
Andrea, just for a practical point of view, you show a beautiful case of ST elevation patient in which you assess the non-culprit lesion after. In such case, do you use to perform again the QFR before starting the treatment of LID, or you use the offline values that you get from the MI procedure? Do you think that could be a red alert to repeat or not some changing like in FFR, or is more stable, more reliable? What's your?
We have already evidences that the QFR performed with the angio acquired during the primary PCI. The primary PCI is completely comparable to the follow-up. So we don't perform another analysis during the PCI, the stage of PCI.
That's a big difference with invasive physiology.
Yeah.
Invasive physiology changes in the next procedure. Let's take this question quickly because we have time.
Yeah. I have a question for the CT-guided PCI. Do you see the patient in the angio, you see that he has calcification, and then you send them to CT to get another bolus of contrast metal and radiation? Or is it for the patients who were screened for coronary, for CCS, and then were found to have calcific lesions? Which patients would you use?
The patient was sent for a CT for a screening because he had a chest pain, a throat angina. So he was referred to CT scan for screening, and then was referred to our cath lab.
Great. Now, let's move on then. We have Michael Joner from Germany to discuss pre-solve a step beyond the drug-eluting stent plateau. So how do we leave nothing behind?
Okay. Thanks for having me. It's a privilege to be part of this wonderful symposium. Thank you so much. So this is my conflict of interest. Where do we start? Of course, I mean, many of you have seen the slides for decades now almost. But I think when you look, let's start at the right panel of the slide. You focus only on that one with your eyes, please, because that is the hardest endpoint in terms of target lesion failure that we can get, which is stent thrombosis. And as you can see, there is an accrual over time of these events in no matter what kind of drug-eluting stent, and these are most contemporary devices you're looking at. So this clearly tells us something is going wrong, and I think this counter-argues all the people that say that drug-eluting stents have solved the issue of treating coronary atherosclerosis. I'm sorry, but that's what it is. So what do we need? We need some better technology. I'm not sure if I can present the optimal technology tonight here in this session, but we have to try it and we have to be brave and look at new technologies that can eventually overcome some of these issues. We need lower thrombogenicity, and most of all, we need to avoid the issue of neoatherosclerosis, meaning the new growth of atherosclerosis within the stented lesion, which probably accounts for most of these late thrombotic events. So why would you work with magnesium? So we've heard, a decade ago, the rise of polymeric bioresorbable scaffolds. Unfortunately, it came down because of a risk, again, in late thrombotic events, and the issue was supposed to be the late scaffold dismantling. So you have to control that. You have to be much quicker in terms of resorption. And this is what is so excellent with magnesium. The radial strength is different compared to polymers because you have a performance that is similar to any drug-eluting stent when you implant it. It needs to be biocompatible, and that's true. We've shown thrombogenicity is extremely low. And you can do something very basic, which nobody's speaking of, which is electropolishing that everybody of us is used to with all drug-eluting stents. This is how it looks. The FreeSolve is the new iteration, or I shouldn't say iteration because it's a completely new device. It's composed of a new magnesium alloy, and you can see that it has thicker stent struts compared to its predecessor, Magmaris. It goes down to 99 microns for a 2.5 millimeter device, 117 for the 3.0 and 3.5, and then it's 147 for the larger device for the 4.0. You can also see that a new marker concept was employed to improve visibility of this device. And all of that taken together, let's look at the preclinical data that are available for this device. I will keep it very simple, don't worry. But what I want to point out is that you can measure strut discontinuities. The dismantling was the big issue with Absorb. And when you look at the most critical time points, 90 days, 120 days in preclinical models, you can see compared to its predecessor version, the Magmaris, which is in gray, you can see the number of strut dismantling or fractures, call it whatever you wanted to, is significantly lower. And that tells us on the right panel then, if you translate this into radial strength, and this is finite element simulations from preclinical data, at 3 and 4 months you can see a significant improvement in terms of radial strength. Now, with regards to the OCT visibility of this device, you can see that we did a very sophisticated analysis looking at each individual strut, and you can see 99.6% of the struts are being resorbed, no longer visible at 12 months. And on the right panel, you can see how this translates into clinical science, and this is from clinical data that was done also by Hector Garcia and his core lab. 99.3% within the BioMark-1 trial were resorbed. So there's excellent correlation between preclinical and clinical data. Now, this is the first in-human trial, BioMark-1, which was presented and published some time ago. And you can see on the very right side the cumulative late loss curve. And for you to make it easy, the greenish BioMark-1 curve is compared to the predecessor Magmaris device, which was investigated in the BioFlow, and you can see that there is quite some substantial reduction in late lumen loss. So it's a left-shifted curve in terms of late loss. So also that was clearly improved, and there will be follow-up up to 5 years in the study also. I have shown this already. This is some consecutive OCT data just to show you that early on when you look at the post-procedure image, it looks like a metallic drug-eluting stent. It's hard to differentiate. Then at 6 months, it's already barely visible. Actually, when you have the eyes of a core lab, and Hector will confirm it, you have to look very carefully to recognize the stent struts. And at 12 months, I can reassure you, there's nothing that you can detect, basically. Maybe from now and then you see a remnant, but that's it. There is no strut dismantling, no in the lumen sitting of stent struts. It's covered in the tissue. And then I want to show one of the studies. We had the privilege to work with Hector Garcia, and what he did basically, which was very important, he tried to understand how does the tissue develop, how does the underlying tissue impact on vascular healing, and how does the tissue on top of the struts that is growing develop over time. And he used a dedicated software, the OCT Plus software, which has an AI algorithm to differentiate different tissue types. And what you can see here is it's able to really differentiate fibrous tissue from lipidic tissue and from calcified tissue. For instance, the white area shows you all the calcium. And what he found is quite interesting, because he showed that there's a 20% decrease in lipid area underlying these stent struts, and at the same time there was a 36% increase in fibrous tissue, especially above the struts. So that means that the fibrous cap is forming. One of the dreams that eventually, we were thinking of, that you can cap such more, let's say, progressive vulnerable lesions. So this doesn't account for all the lesions we're looking at, but in these vulnerable lesions, it may be an important point. And he shows this here, that it's especially growing on top of the stent struts. Now, I want to point out that there is a randomized controlled clinical trial going on, the BIOMARK-2 study, and this is really randomizing 2-to-1 against Freesolve against science. It's a very brave but also very much needed study that is going on around the globe. To target lesion failure at 12 months is the primary endpoint, and you can see it targets at 100 sites around the European and Australian continents, 21 countries currently enrolling, and I was updated this morning, actually, 619, not 537 patients have been enrolled. So it's unbelievable how fast this is enrolling, at least to my point of view, given the fact that there was some reluctance for bioresorbable scaffolds. So there seems to be a lot of interest in these different countries with regards to bioresorbable scaffolds. With that having said, thank you very much for your attention.
Thank you, Michael. Very important technology as well. We'll discuss it together with your presentation, Enrico, if you want. I think you are showing us some real-world data, your own experience from Italy, and we are curious to see your data.
Okay. Thanks for the invitation to that symposium. It's clearly that for a long time we have been used to perform invasive intravascular imaging and physiology in order to ensure our optimal treatment outcome, and therefore we start implementing so-called offline angio-based invasive. As we already speak today, is probably time to move to offline to a live angio-based analysis, as Andrea clearly showed. But I would like to show you a case of a young man that was scheduled to treat this long LID disease with resorbable magnesium scaffold implantation. I think that in that case we can also combine together angio and anatomical information, because we need to know a lot of things. We need to know if really we need to treat. We would like to know if we have to treat lesion A, lesion B, both of two. The correct sizing, probably the morphology of the plaque, if it's feasible for a resorbable scaffold, and also we need some information about residual functional assessment. So to treat that case, probably the best thing is to combine together the full angio-derived physiology and also imaging. That, like in such case, you can clearly see that there is a severe functional stenosis in the proximal LID. We can know about length, we can know about reference diameter. In this specific case, we also perform imaging, as you can see here, analyzed by QFR software, and it's really impressive how the information that we obtain by QFR is comparable and very similar to those that was provided by OCT, but OCT also had information about the type of plaques. So we treat the patient according to a correct sizing, correct vessel preparation. We implant a single magmatic scaffold 3.25. We perform a post-dilation, and this is the final angio result. And again, we can obtain information immediately after about physiology, about the resolution of the ischemia. And again, we can get information about optimal expansion, optimal position that was, again, very similar if you look at number comparable to those provided by the non-invasive angio by QFR. So in such a specific case, we used to perform a clinical follow-up for that patients that implanted resolvable scaffolds. This is a 1-year follow-up of those patients. As you can see, there is a remarkable angiographic result. But again, for research purpose, in those specific cases, we perform again physiology to reassure about the result. And again, we perform again imaging to have an immediate impact about complete resorption of the scaffold. So what we can learn combining together physiology and imaging. Some years ago, we performed a study trying to investigate such patterns. We include 44 patients and 47 lesions. Also, Andrea Ricketts from Ferrara helped in those big work. It was a big effort for us at that time without the actual 3.1 QFR software to obtain the analysis, and again, it was a great effort for the core lab to analyze slice for slice and have a pairing analysis pre-PCI, post-PCI, and 1-year follow-up of such data. But we can learn a lot combining together that information. As you can see, we can have anatomical information and also functional non-invasive information. If you look at the anatomy, we know that we can have some late lumen loss in the vessel. We know from the Magmaris platform, probably we hope to have less late lumen loss with the new freesolve platform. We can have a perfect vessel healing. In such studies, 44% of slices have a golden tune pattern, and there is some residual humps, but no really visible stratum was identified. But if you move to the physiology, is very interesting that in any case, also in presence of some kind of lumen loss in such cohort of patient, we obtain a fully preserved QFR physiology result at 1 year, demonstrating that despite a potential lumen loss of the vessel, we can have a restoration of the normal flow without residual ischemia. But we really need nowadays to perform an invasive follow-up of those patients. It's clear that we can have other way. We can use also non-invasive CT scan. We already view today that we can use to plan the procedure, but in such case, we can also use to follow up the patient. In that specific case, we have a CT follow-up that could demonstrate that we can identify the tantalum marker of the Magmaris in such patient. We can have information about plaque analysis. In that case, it was 75% fibrotics, and we can have also 3D volume reconstruction of the vessel. This specific patient was included in this case series that we published some years ago, demonstrating that it was feasible to perform a CT follow-up in such patient, and we can observe, it's true, a mild in scaffold late loss, but we can also have a detailed coronary plaque characterization that was prevalent to fibrous fatty plaque, and notably there is a majority of patients that start the pathology with acute coronary syndrome. So what we learn from angio and CT-based analysis? We can see that basically the time is come to move from offline to live angio-based analysis that could be implemented in our cath lab in nowadays practice, but beyond the physiological assessment, the methodology like QFR could also provide some anatomical information that could help in optimal device sizing and implantations that could be especially important in patients that have to implant a resorbable scaffold to correctly size the vessel. It's true that we need intravascular imaging when we need to assess plaque morphology information. The non-invasive CT-based analysis is something that could be feasible to follow up those patients, because we know that using the current software we can properly identify also the area that was previously treated by resorbable scaffold, and we could identify the tantalum marker. We could have good information about the stabilization of the plaque. If you would like to know more about long-term follow-up or resolvable scaffold, tomorrow I will present in the late-breaking trial section the long-term result of the Sherpa Magic Registry, the all-comer registry of Magmaris implantation. Thank you very much.
Thank you, Enrico. So we'll have very few minutes to have a conversation. So the reason why we put this symposium together is because one of the therapies, the technologies that benefit from a very strict and planned protocol for the implantation is the resorbable magnesium scaffold. Is different from the metallic that is more forgiving. So Michael, we need a 4-piece, and a combination of these imaging technologies would really help us to get there, right?
Yeah, I mean, that is quite obvious that, initially when we started, we said, there was concern that if you have to use IVUS or OCT in every case, that it may, prolong procedures, it may cause fatigue of the operators to really implant these devices. So as I'm seeing these, more or less online developments occurring this is just amazing. I think this would be the future probably if you combine it with a bioresolvable scaffold technology.
And the clinical results, the angiographic, but also the clinical results are great so far. We don't want to spoil another technology by doing implantation as we did in the past with any guidance, with any planning. And so I think Enrico was showing some nice examples of that. So we have to understand that this technology has expansion limits, and it requires proper sizing. So Enrico, the case examples you show, very nice correlation between OCT and QFR, geometric dimensions for guiding your sizing. How confident you feel now using QFR 3.1 for implanting Magmaris without OCT?
Yeah, I think that in such setting could be very, very useful because while we start using resolvable technology, we prefer to using almost 100% imaging because we really would like to know to implant at the best the scaffold. But now we have more practice, we know better the technology, but we still, I think, need some guidance. So QFR could be the perfect guidance, I think, to help us in the correct sizing. Maybe if you need the morphology information at this moment, you need to perform IVUS or OCT.
Thank you so much. So we have learned a lot. Of course, we have the Medis booth, the Biotronic booth, also at the training village where we continue to hammer the same concepts. We were allocated this period of time and it's coming to an end. So Joanna, why don't you help us to summarize and conclude?
Sure. So what have we learned today that we can take to practice? I think we learned that QFR 3.1 is actually a great solution to plan your procedure and to optimize your PCR results. And it is at your fingertips because you have an iPad that you can use in your cath lab. You can you already are doing an angio and you're only using the information that's already there with a sophisticated IE tool that works in 30 seconds and 5 clicks. So what we started with is that it's not only important to assess the lesion as a diagnostic tool to say, yes, I need to put a stent, or no, we don't need to treat, but it's extremely important to actually check your final result. And I can tell you from my own experience that nothing is more satisfying than achieving this above 0.91 value post-PCI and being able to tell the patient that you actually reduce their risk of coming back to the cath lab. So, and this is confirmed now actually in the difference between Favor 3 Europe and Flavor 2. So when you use this technology properly and when you also use it for post-PCI optimization, you actually achieve equivalence in results to IVUS guidance. When you don't, as in Favor 3 Europe, then you can run into problems. And you see that in the primary endpoint, which was excellent for Flavor 2 and not so optimal for Favor 3. And I believe that we'll get some insight into the reasons for that sometime shortly in the sub-studies. And of course, the device is not non-important. So we have seen from Michael the continued accumulation of events in terms of ischemic events for the metallic stents, regular deaths. So something that is not left behind, which resorbs within 1 year, that has a good radial strength, like the Mahmaris. Bioresorbable device is very promising. You could see the look to the future, and maybe we could also passivate the vulnerable plaque with this device. The studies are ongoing, and of course, the planning for those procedures is essential. And I think what was shown in the last presentation very nicely, that we now have a huge armamentarium of techniques, starting with the CT scan prior to the procedure, where you can get plaque features, when you can get the CT FFR through during your procedure, confirming everything and doing additional diagnostics and optimization based on QFR, and then when needed, using also perhaps intravascular imaging if you see that your QFR is not optimal and you want to pinpoint the problem. All right, thanks.
Thank you so much for your attention. Thank you, Medis. Thank you, Biotronic, for the sponsorship. Thank you.